Good evening, everyone, and welcome to the ASMS webinar on Mandible Fractures. I'm the Executive Director of the Society. My name is Stan Alger, and our presenters tonight are Dr. Delora Mount from the University of Wisconsin-Madison and Dr. Alexander Lynn, who's from the St. Louis University. And we will start with Dr. Mount. And before we do, a couple of things. In the lower right-hand corner of your screen, you will see there is a chat box, and you will see that I have already entered in a welcome message and the instructions to use that chat box for any questions you may have over the course of this evening. And then later in the webinar, I and the presenters will look at those questions and answer them accordingly. Also wanted to remind those who are not members of the ASMS, this is a great benefit of membership, attendance to these webinars, as is many other benefits of membership, which you may or may not be aware of, including discounted registrations to the meeting programs, journal, all kinds of wonderful things that the Society does for its members beyond the webinars. So please consider membership and to visit www.maxface.org. After the webinar is concluded and has ended, you will see that the website will automatically appear. So at this point, I will hand over the presentation to Dr. Mount. Thank you, Dr. Mount. Good evening.
Thanks, Stan. Thanks for that really great introduction. I just want to make sure that everybody can hear me adequately. You don't necessarily need to see me, just getting out of the OR, so I pretty much probably look a lot like a lot of you guys. A little tired, but here to learn and talk about mandibles. So basically, I want to go over some of the objectives of our webinar tonight, which we want to review some of the anatomy, particularly some salient features about where fractures commonly occur in the mandible. We'll talk about bone healing, both primary bone healing as well as secondary or callus healing. We'll talk about the principles of stable internal fixation, which is kind of the hallmark of mandibular fixation. And we'll talk about what's meant between load sharing and load bearing type of osteosynthesis, basically how either the plates arrange the bones so that they provide the support, or if the plate itself is the support. I'll talk also a little bit about surgical approaches. It's actually a part of a shorter aspect about surgical approaches. And then we'll discuss proper plating techniques in my portion of the section. After completion of my portion, then we'll move on to Dr. Alex Lynn, who will go over some cases, hopefully generate a little bit of discussion and questions, and we'll just have some fun on a Thursday night with mandible fractures. By the way, I have no disclosures. I won't be talking about any sort of plating companies or specific plates, just in general, either a bicortical or a monocortical. So the really great thing about the mandible, and also the thing that ends up being difficult about the mandible, is its three-dimensional structure. Obviously, here are the condyles where the head of the condyle fits into the fossa, and then, oops, here. And then we look at it from the below view, you can see that the structure is really not a semicircle. So don't even think about it as being a semicircle. Think about it as really being an arch form. And the arch form is really key to maintain in reduction of any of the fractures. Now, I put this in here for Alex. Alex is running just a slight bit late for our webinar tonight. But Alex is from St. Louis, at St. Louis University. And for any of you travelers, you know that this is the gateway arch to the west. And this is a perfect example of what the mandibular structure looks like from below. Again, breakaways here include the red area, which is the subcondylar area, the coronoid process, the mandibular ramus, the body, the parasymphyseal region, as well as the tooth-bearing segments. So this is a unique area to have fractures because not only are you dealing with the three-dimensionality of the bone, including two joint spaces, but you're also dealing with the dentition. And the dentition can hurt you, it can help you. Most of the time, helps you. Now, when we look at where fracture patterns occur in the mandible, you can see that a really common area is the subcondylar fracture area. This constitutes about 36% of fractures. About 2% are going to be an isolated coronoid. That's a really unusual fracture, and you have to be thinking, what else is broken? Is the zygomatic arch broken? I'll show you kind of on my little model here. Because as you see, that this area of the coronoid process is nicely protected with the zygomatic arch and also the temporalis muscle. The mandibular ramus is about 25% of fractures, and the body about 20% of the fractures. So the majority of the fractures are really going to occur in this region right here. Another 3% occur in the alveolus just as an isolated alveolar fracture, and 14% as a parasymphyseal or symphyseal fracture. Now, how do we assess this? Well, the cheap and dirty way is to actually get a panoramic or orthopantomogram, Panorex. Panorex is actually the trade name, so that's one trade name I will use. And with the Panorex, if you've had this study done before, the machine actually, you sit up or stand up, and the machine actually rotates around like this. So you do have to have someone that, first of all, can be able to sit up, that isn't on C-spine precautions, or that isn't so terribly intoxicated that they can't, or comatose, that they can't participate with the imaging. So the adult Panorex is actually a really, really great modality to use. They're cheap. They're like maybe a couple $100. And you can see pretty well the definition of the condylar head here. You can see even the joint space. You can see the ramus. You can even see the nerve as it traverses, as the nerve foramen, as you can see here, kind of traversing right through that region up until the mental nerve coming out. Also key in the Panorex is the fact that you can see the health of the tooth roots themselves. You can see if they're, injured, if there's a periapical abscess. You can see the kind of restorations and dental care that this patient has had before. And so this, for a very, very inexpensive x-ray, is actually quite nice. Most of the time your patients are going to come in, though, either getting a combination of a panoramic x-ray or a CT scan. The CT scan is going to show you a lot more of the three-dimensional capability of things, but a little less crisp as far as really seeing the health of the teeth and the tooth roots themselves. So don't get spoiled just by the CT scan, because in your follow-ups, you're definitely going to be following with panoramic x-rays. Now with children, we've got a whole different aspect here. This is a Panorex on a kid that basically can't hold still. I mean, again, you have to be there while this panoramic x-ray goes all the way around. Kids tend to move around, so you see a lot of motion artifact. But you can see the condylar heads. You can see the subcondylar area on both sides. You can see the ascending ramus and the body and the parasymphyseal area. But where it really gets muddy is when you're looking at the teeth, particularly the primary teeth and then the secondary teeth that haven't erupted yet. I know that Dr. Lin is going to show some photos and some case studies of some difficult cases. And particularly with children and mandible fractures, they are hard. And you got to know that the kid's mandible is different. For example, when you look here, you can see the mandibular canines. Actually, the root itself actually goes to the very inferior caudal edge of the bone. So this is not going to be a patient where you can put a plate across here without damaging some of the permanent teeth. Other things that that you'll notice are, even here where the third molar is going to come in, you can't even really see it. Oh, I think Alex is joining us now. Alex?
Yes, I believe he is.
Okay, great. Maybe let's mute.
Hi, Del. Hi, Stan.
And the other thing about children's mandible fractures are the fact that with that really high rate of subcondylar fractures, this is a growth center in the subcondylar area for future mandibular growth. So these are going to be kids that, with a subcondylar fracture, you're not going to open, you're not going to do extensive dissection because, again, that's a growth center. So let's talk a little bit about bone healing. So there's primary bone healing and secondary bone healing. Primary is the good kind. That's the kind that we strive for with every mandibular reduction. So there's really no callus, which is just basically fibrotic, osteofibrotic tissue. But with primary bone healing, you get direct bridge osteons. So really those that bridge occurs quickly. There's bony deposition. There's normal remodeling afterwards. And there's really not space for instability, and it's very low risk for fibrous malunion, which is one of the terrible complications that can occur with mandibular fracture reduction. Now, secondary bone healing is healing by callus. This is going to occur when perhaps the bone segments are really comminuted, where you don't have a great reduction and a little space in between that leads to a fracture hematoma. Kind of moving into that area. When it does that, obviously fibroblasts are going to get in there. They're going to start making all of their fibrous healing tissue in response to the fracture, and really try to heal the fracture the best that they can as not being osteon to osteon. And because of that, you can actually get a fibrous malunion. And if you want to think about fibrous malunion, just think of it as being scar tissue that develops between the bone edges. And that's bad, because that's not going to be terribly stable in the long term, and is very high risk for developing infection. So think about, again, primary bone healing as being kind of our gold standard, what we're aiming for with adequate stability, and secondary bone healing as being kind of what we want to avoid, if at all possible. So here's a question for everybody, just to make sure everybody's still awake on the line here. And I see we've got 12 participants, so feel free to wave your hand. I don't know if any of you guys have your monitors turned on, but how do we assure stability of the fracture? So if primary bone healing is really our goal, how do we get there? Well, do we control the tension zone? Do we fixate the compression zone? Do we really base it totally on occlusal relationship? Well, the answer is, and I'm sure you guys have all figured this out, all of the above. So during our reduction, again with this three-dimensionality, we're going to try our best to get the bone pieces to line up exactly properly. We're going to get our arch form, again the St. Louis arch, to really line up in a proper arch form so we don't have crossbite. And then we're going to fixate it to control for tension and compression zones. So let's go over what the mandibular stressors or the zones are that we need to fully understand to do an adequate job. So there's a zone of tension, a zone of compression, and then, as I had mentioned before, we'll talk a little bit about how the reduction can be load-sharing fixation or a load-bearing type of fixation. So the mandibular stressors really are very muscular in nature, and so you can see that the action of the masseter, which is represented in the green here, is trying to pull the mandible up to the skull base. And then a secondary one is going to be the temporalis, which is attached to the coronoid. Again, the muscle slings are pulling up the mandible towards the skull base. Now, when you eat a bite of an apple, and you put an apple out here, you can see that the teeth, when they clench together or occlude together, are going to push downward. So we've got these opposing forces. and we have to control for that. So normally after a mandibular fracture reduction, we're going to try to control for the bite force by having them on a modified diet, right? And we're going to definitely try to control for the muscular force by plating out to length and making sure we've got adequate reduction. So again, this is kind of a schematic showing the muscle pull and then the bite force pushing down. So if you can imagine that, and I'm going to try to do this with my hands, I don't know if you guys can see it or not, but in a mandibular angle fracture, as you bite down, it's going to tend to tense or open up in this area right along here, and it'll tend to compress the caudal segment or the distal segment here. So that's what they mean by zones of tension, which is going to be this area that tends to open up with bite force, and a zone of compression, which tends to close down with bite force. All right. So all of those need to be taken into account. So we can control the tension, meaning that we're going to prevent it from opening up at that cephalad edge when bite force is applied. We can actually control that by putting a little monocortical plate in that region. How do we control the zone of compression? Well, this is the actual reduction area. And this is where we're going to place our bicortical plate if we're plating at the caudal edge of the bone. Why not a bicortical plate and screw fixation up at this proximal edge? Well, because the tooth root for the second and third molars, and sometimes even the third molar, is involved in this. So we want to stay with just a monocortical screw at that area so that we don't injure the dentition. Now, what if our fracture is a little bit more, what we call this mesial, so there's a fracture truly in the body? Well, do we have to put on a control tension and compression? Well, no, we can actually put on something very cheap, something called an interdental wire, and that is actually going to help control our tension, and then do our regular plate, our bicortical plate at the caudal edge. And again, you know, as I showed you with that panoramic x-ray, the inferior alveolar nerve travels right along here. So we definitely don't want to put the plate here because we'll hit the nerve. So we want to get it as far caudal as possible. Now, the last type of reduction that I'll talk about is the utilization of the Champi technique. Now, the Champi technique, these are called the Champi's lines. And the Champi's lines are another area of stability or buttressing, if you will, of this three-dimensional arch of the mandible. Now, you can imagine that an undisrupted, meaning that we haven't gone in and taken down all the fibers of the masseter, that we're still going to have pretty good, pull up this way, so that that muscular sling can actually pull the mandibular bone up towards the skull base. If we utilize a monocortical plate to place along the Champi line like this, and we could just make an incision intraorally and place that down, we know that with bite force, we're going to have enhancement of our zone of compression. So the zone of compression doesn't necessarily need a plate on it if we have a Champi plate. So I know that that's kind of a difficult technique to think about the Champi plate. Oh, I'm seeing an arrow from somebody. Is that you, Alex? There's a green arrow that just came in. But anyway, the Champi technique is a very nice technique, but can only be utilized in very select fractures of the mandibular angle. Now, how do we, so let's go back to load bearing, load sharing. So when you can get absolute bone-to-bone contact in the fracture line and get the lining alignment just like you want it to be, then you can actually even use a mini plate, because all you're doing is assuring that those forces are controlled, okay? The plate's not doing anything else, as far as carrying a load or anything like that. It's just basically keeping those bone edges close together so that the bone edges can do their thing with primary healing. Now, for what's called a load-bearing situation, would be if there are gaps or some instability. So like a comminuted fracture where there's not really, good bone-to-bone healing, what you may do is you may span that entire area with a very strong plate that is going to carry the load of bite force as well as the zones of compression. And so with load-bearing plate, those are the times that you're going to use things like the big reconstruction plates, the recon bars, and then if you can get into a primary healing situation, you can use even mini plates that have shown to be adequate for reduction. So approaches, and I'll finish up here with my part in just a moment. Obviously, we want to use a combination of occlusion as well as visualization of the fracture and mobilization to get our optimal primary bone healing. So this may include placing arch bars or IV loops, circummandibular wires, piriform wires. I can't remember the last time I had to do this. But anyway, all of these things are available to you. I would say most frequently lately, I've been using a lot of arch bars that are the hybrid kind that you just basically screw in quickly. It saves you about 45 minutes. And then not all mandible fractures actually need to be repaired, but they do need to be followed. Like this gentleman here had a fracture here, but very minimal displacement. We just controlled his bite with a soft diet and continual checks. We can approach through the buccal sulcus. Obviously, we have to be really careful about avoiding the mental nerve, but you can see that you can put on a big recon bar, again, for this comminuted fracture. And this is a load-bearing plate. And then this load, or this smaller fracture here is just basically to tackle those little pieces together. A Risdon incision in the neck or an extended Risdon like this patient has, you know, it's, I would say, a secondary. I like to do the intraoral incisions with a transbuccal trocar instead. I just think it's easier on the facial nerve and much less likely to cause problems. And then very rarely are you going to have to use things. This is a gentleman I took care of that actually had a large gunshot wound and a big segmental defect that I just needed to keep at length in preparation for a fibular graft. So that's all for at least the introduction. We will have you guys wait for questions until Dr. Lynn's portion. He's going to help us take some of these principles and some of these thoughts into clinical action. Go ahead and take it away, Dr. Lynn.
Yep, and we'll give Dr. Lynn a few seconds to activate his microphone. It usually takes a few seconds to get it back online. Dr. Lynn, once you're ready, you can proceed with your presentation, and I will close out Dr. Mount's presentation.
Testing, testing.
There we go.
Testing, testing.
We can hear you.
Can everyone hear
Very
me?
well.
Or
Yes, we can.
I guess typing testing, testing is not helping. But
Very good.
Okay.
You may proceed.
well, great. Del, do you think we should see if anyone has any questions so far? I know we just talked about at the end, but just in case, or
People can ask questions right in the chat room in the lower right-hand corner. Feel free to type. If nobody has questions, we'll proceed in another couple of seconds.
I think our raise the hand functionality is working too, right?
Yes, it is. If you would like to raise your hand, you'll see at the top of the screen there is a feature which I think Dr. Mount just she just demonstrated. So feel free to do that as well.
we're all adults. I mean, we can just chime in. Wow, that's funny. Okay. Okay, well, I don't have disclosures, and it's a fun topic to do the mandible, because if you think about all the bones of the face, probably the one that's most identifiable by a layperson as being a human bone would be the mandible bone. All the other craniofacial, maxillofacial bones are pretty hard to conceptualize, but for some reason, the lower third of your face is just one bone. And I think that's the reason why we focus so much on the subunits of the mandible, because it's way too big for a single facial bone. And so, like Dr. Mount was saying, we can categorize this into different areas, and one simple way is to combine symphysis and parasymphyseal together in the center. and then the body is between the canine and the last molar. The angle and the ramus is everything that's not the condyle and the coronoid, and then you can treat the condyle and the coronoid separately. Can you see the pointer? Good. So I thought I would take you through some of the practical things when you think about taking a patient to the operating room with a mandible, and you want to think about the pre-op, the intra-op, and the post-op. So preoperatively, you need to rule out other injuries. In high-impact mandible fracture mechanisms, you have to rule out the injuries to the joints above and below. So that's my way of remembering the brain and the C-spine. So you got to rule that out. And then your history is very important because you have to figure out what the patient's pre-injury occlusion is. And nowadays with cell phones, you can see photos fairly easily. But if someone's already class 3, you're not going to get into class 1. So you need to confirm what their pre-injury occlusion is. Your physical exam is critical, of course. You have to see if the malocclusion symptoms are real. Is it because there's an open bite? Is it because there's a tooth in the way? Are they experiencing TMJ symptoms? Are they experiencing nerve symptoms? And you have to establish that preoperatively. And then imaging can get plain films, but these days CT scans are very common in the emergency room, and they really give you much more detail than a plain film. And finally, you have to think about the anesthesia airway, and usually you will need, in an isolated mandible fracture, a nasal intubation so that you can achieve occlusion and match up the wear facets in the operating room. So what are the steps for intraoperative repair? I think this has changed from time to time, and I remember back during training we used to teach you immediately put arch bars in everyone, but I don't think that's the case anymore. I think the order has changed for most people. It's not wrong to do arch bars first, but the problem is if the fracture is extremely displaced, you can't even get the arch bars on. So I think a reasonable algorithm is to first attempt a closed reduction. And you try to get that as best as you can. If you've got it, you're done. You don't have to do anything else. But probably you won't be able to get that done, and then you'll have to expose the fractures for open reduction. And like Dell talked about, there's intraoral, extraoral, and transcutaneous incisions you can make. Then you have to reduce the fractures in central relation. So now you have all the fractures opened, and now you can visually reduce them into the correct position. But while you reduce it, you have to keep the TMJs in central relation. And once you finally have that correct, and you've reduced those fractures, you will then maintain that reduction with maxillomandibular fixation. So for me, that's usually when arch bars go on, or nowadays maxillomandibular fixation screws, or MMF plating systems such as hybrid MMF or the WAVE system are becoming popular. Now, just like finger fracture where you hold the fracture reduction in place, you now are kind of holding your fracture reduction in place, and that's when you fixate the fractures using a combination of wires, mini plates, recon plates, or screws. When you have everything fixated and ready to go, that's when you release the maxillomandibular fixation and check again that you're in central relation and that the jaw is fitting into the other jaw into the correct occlusion. And now it's your job is to determine whether you're going to restrict the patient postoperatively or just let them hang. So if you have very good, strong internal fixation, you will probably return them right back to soft to normal diet. If you are trying to reduce the amount of hardware, such as in a pediatric fracture, you may have to rely on MMF or maxillomandibular fixation to gain enough stability to let the bones heal in the right place. Finally, in the specialized case of condylar and subcondylar fractures, you may actually opt to do minimal stabilization and work on guided elastics. So that leads me to the last part, which is postoperative care. You can consider postoperative imaging. That's a dealer's choice. If it's very straightforward, I don't think you need to. Otherwise, if it's more complex, you may need to follow it sequentially, or if a patient reports new symptoms, or in a more complex panfacial fracture, you may even need a postoperative CT scan. And then you have to determine how long you're going to restrict range of motion if you are restricting range of motion. And I think in an average adult, 3 to 4 weeks is enough to gain enough stability. You don't want to go too much more than that because then you risk injuring, you restrict the TMJ. You may need guiding elastics up to 6 to 8 weeks depending on the fracture type. This again is a little bit more for subcondylar fractures or fractures where they're not truly reduced. And finally, if you left any hardware in, like wires or Ernst ligature or things like that, arch bars, you can take them out after you're confident everything's fixed, and that may be up 6 to 8 weeks or later. So good. So with this strategy, we can go after every fracture in the mandible. So let's talk briefly about fixation guidelines. Dr. Mount showed us the different ways both load-bearing and load-sharing can allow stable fixation so that the bones can heal in 4 to 6 weeks. So one way to think about it is in the upper case, if they're stable, the fracture is relatively stable, you have multiple ways of keeping it there. It could be as simple as MMF, and then it'll stay because it's a stable fracture, it's in place. Or you can have a relatively weak mini plate that needs a countertension. And what is countertension? Well, countertension is a single plate doesn't control the yaw around the plate, so you need some kind of countertension. Traditionally, you think of a wire loop around the teeth that are at the superior portion of the fracture, or arch bars can act as a countertension, or an additional plate. Really, though, there's 3 other ways to do countertension, and the 3 other ways are a box plate. A box plate is basically like a built-in countertension because now you're reducing yaw, or the maxilla. That's really MMF. So MMF in of itself can be sort of a countertension, and an osteosynthesis line. That's one way to think about a Champi plate. A Champi plate is a single plate with no countertension because the osteosynthesis line is its own countertension. Now, if you have an unstable fracture, and that usually means a common unit fracture, then you need to consider additional fixation, either multiple plates or a single recon plate, or a single recon plate with additional fixation, such as additional plates or an external fixator. I agree with Dr. Mount, an external fixator is pretty uncommon. I've only used it in gunshot wounds. I can't think of any time when it was a non-gunshot wound that need an external fixator. But it's good to know that there are as many gunshots in Wisconsin as St. Louis. That's a great feeling. So let's start with the parasymphyseal and symphyseal region. You know, this is really tough on me because I cannot hear what the audience is. I'm used to hearing some kind of feedback, but it's a little tough here. Are there really other people on? Maybe someone can type something so I know there's actually. Oh, good.
Actually, you can tell by the number of participants, we currently have 15.
Oh, good. All right. Well, then it seems like someone is there. That's a good feeling. It's like the operating room, right? If no one's responding and something's going wrong. So we can classify parasymphysis and symphysis together, and this is a great website. I think one of the 2 best references are the Ellis Book of Surgical Approaches to the Face and the AO Foundation website. Excellent guides that'll help residents and junior attendings. So they're classifying this as simple and complex, so I think that's a very reasonable way to look at it. So let's use those principles we just talked about and look at the simple symphyseal or parasymphyseal fracture. On the upper left-hand corner here, you can see that what you can do is if it's a very straightforward, well-reduced fracture, you could just do maxillomandibular fixation, in this case with arch bars. And that would be stable enough to have this heal in about 4 weeks or so. On the upper right-hand corner, you see the use of a lag screw. This is a really great, very stable fixation, just like when you do it for an oblique metacarpal fracture. The problem is it's a little bit tricky in this area, and I have to admit I've never done it, even though I keep looking for an opportunity to do it. I think the problem I have with this is unless you have x-ray vision and we don't have fluoroscopy for facial fractures like we do for hand fractures, I would be so worried that my lingual cortex is flared, and it's such a stable reduction that you'll never correct that. There will be no remodeling. So I think theoretically this is great. And then on the bottom here this is also very unusual to do a lag screw and a countertension. And then on the bottom right, that would be much more common, which would be doing a mini plate with a countertension plate. Now, some people, myself included, would probably not use that mini plate if I had either really good arch bars around this area, or I had a good Ernst ligature or ivy loop around the teeth surrounding the fracture. To me, unless it's an extremely unreliable patient, I think that's stable enough countertension. Now, if you have a comminuted fracture, then you have to bring out the big guns. And so on the upper left here, not only is there a larger mini plate, there's a countertension bar. And on the right, this is the example of an even thicker true recon plate like you would for a cancer operation. And above, you have arch bars that provide some degree of countertension. Some people think, and I think this is appropriate enough, is that a large recon plate would not necessarily need a countertension, but I would caution you on that. And on the bottom is just another example of the external fixator on the bottom here. Okay, there's only 3 other areas, and then we'll do cases. So the body is another very common site of fracture, and you can classify this as simple or complex. When you look at a simple fracture, again, if it's really a well-aligned fracture, and it could be displaced, but as long as you reduce it, it doesn't mean it's not displaced. It can be very displaced, but if you can approximate it well together, then you can do maxillomandibular fixation, or this is the maxillomandibular fixation with arch bars here. Hopefully you can see the green arrow, but here is an Ernst ligature around those teeth. That really can be enough in a compliant patient with a good stable reduction. On the right here is a more common version where you would put a mini plate and then countertension with arch bars. Now, on the bottom left here is the similar concept where you have a main mini plate and a countertension mini plate at the inferior border for a simple fracture of the body. If you notice here, they drew the Champi lines of osteosynthesis, so theoretically one plate would be enough here, but the body is such a big load-bearing area that I don't think most people will just leave one plate there. I don't know if Dr. Mount would agree with that or not. And then finally, you can also put a large inferior recon plate. Put something this big. Usually you would need an external approach. Maybe you could go either way, but if you're that worried, you probably would go external, especially if there's comminution. Let's look at the comminuted example, and then the comminuted example is trying to show there's multiple pieces here. You really have to consider the clinical situation. Again, here you may need an external and internal approach, or percutaneous screws at least. But if someone has other risk factors, you may want to stay purely extraoral so that you don't have to worry about contamination from the intraoral contents. Here's another example of multiple comminuted fractures along the body and the angle, and a big recon plate is reconstructing it, plus smaller mini plates. Again, the lower example of the external fixator, that's not a common situation. The angle and the ramus. So for the angle and the ramus, we finally get to enjoy the fruits of Champi's experiments in osteosynthesis. And this is really fun. We don't have time to go through it, but the history of understanding these fractures and the war between AO principles of rigid fixation and Champi's principles of mini plates and osteosynthesis. But I think we all accept now that Champi's osteosynthesis lines work very well if you have a simple fracture with good bone-bone contact, so then you can rely on the bone-bone contact to load share, and even a simple wire could do it, but most of us would put a Champi mini plate over this area. You could use 2 plates if you were having issues with reduction, or maybe there's a little bone missing in the bottom, or you can use a recon plate. But there's that famous series of LS patients where there's more infections, as you would imagine, with a bigger plate. Now, traditionally, the other thing to think about for these is that these actually, although relatively simple fractures to fix, have the highest complication rate. And it's probably because of the wisdom tooth. Probably. It's unclear. No one really knows. The wisdom tooth either cracks or is in a line of fracture, and teeth are dirty. But it's not clear to me that completely explains everything, because when we do a BSSO, occasionally we'll do the wisdom tooth will be in there, and we'll shuck out the wisdom tooth before doing a BSSO, and those don't get infected. So I don't know if that explains everything. But regardless, I think a very accepted solution would be this for can you see the green arrow, for an uncomplicated angle fracture, or even angle bordering on ramus fracture. We just did one actually yesterday. And then here for a comminuted fracture, you can see that There's you can put a mini plate and then a mini plate on the body too, an inferior border plate. Theoretically, if on the in an inferior border plate here, theoretically, if you had a recon plate, you wouldn't need a Champi plate, and I think that's reasonable as well, because that recon plate will hold it in place, but you have a lot more hardware to deal with. And here they always throw in the external fixator example. Finally, let's talk about the condylar process, the condylar and the subcondylar complex. This is usually a really confusing topic because it's very controversial. Why is it so controversial? Because nobody knows what the right answer is. That's always the case for controversial things. So you could really summarize it in two ways. You can think about treating it non-operatively with closed reduction, or treating it operatively with open reduction internal fixation. But this is tricky because in this example of closed reduction, we don't really reduce it. We try to reduce it. We try to put a mouth prop on the contralateral side to, a mouth prop on the ipsilateral side to open this shortened height, but it doesn't really probably do it. It just helps it remodel into a better position. So the main issue with the condylar fracture and the subcondylar fracture is loss of vertical height. So this is the main issue here. And when you have loss of vertical height, you have premature contact of the molars on the ipsilateral side and contralateral open bite. So what you need to consider is the ipsilateral height will be shortened, so you're going to have ipsilateral premature contact and a contralateral open bite. So the way I think about it is you really need guiding elastics on the contralateral side. So what's debatable is the initial time of maxillomandibular fixation. Some people think you shouldn't do any maxillomandibular fixation at all. You should immediately just do guiding elastics and let them swing and let them remodel the ipsilateral fracture. Now, if it is a true condylar head fracture, it's really a very brief maxillomandibular fixation. You can't fixate that long, otherwise that bruised condylar head is going to ankylose the joint and you're going to not be able to open your mouth. For a subcondylar fracture, depending on the degree of it, you could consider a couple weeks, not the whole 3 to 4 weeks, maybe a couple weeks, and then guiding elastics. And you have to shorten these times clinically if it's a child, because a child's going to heal much faster. So what are the indications for open reduction internal fixation of subcondylar fractures? Well, the real main indication is a loss of vertical height where it will make a difference. And where it will make a difference if there's more than one fracture, namely a bilateral subcondylar fracture. So now you've totally lost the height of the mandible, or a panfacial scenario where you need to reestablish height so that you can reestablish height of the maxilla and you can reestablish height of everything else on that side. That's really the time to do it. In a panfacial fracture, you may have an open fracture anyways and have relatively easy access to it. Otherwise, you'll have to do a retromandibular incision, whether it's parotid splitting or parotid avoiding. You have a risk of facial nerve injury, but if you stay behind it in a subperiosteal fashion, you will limit your risks. The other two indications that we usually talk about is there is severe displacement of the condylar head into the middle fossa, or interference with chewing. Somehow it's so displaced that it's interfering with chewing. So those are your consideration for it. Usually it's really what we did in the previous slide, which is maxillomandibular fixation in a very calculated way. Okay. Well, let's just talk about a couple more special scenarios, and then let's do some cases, and so everyone can go to sleep and dream about mandibles. Okay, so some special considerations are combination fractures, multiple mandible fractures, other facial fractures, pediatric fractures, and geriatric fractures. In the combination fracture, I'm simplifying it here, but really it's not that complicated. It's combined, but it's not necessarily complicated. And the way I really treat each fracture separately and then consider the stability of the whole system. So just because there's more than one fracture doesn't mean you have to do anything that different. You still have to gain stability. You still have to get bone to heal at each site. But you may have to consider the whole system. You may increase your odds of doing maxillomandibular fixation and leaving them locked in as an additional stabilizing measure. In the panfacial fracture, we already talked about it. The key is establishing vertical height. And you may need stone models and splints because the maxilla is no longer available. And so that's something the ASMS basic course would be a great place to learn how you make a stone model and splint to reestablish when you have a multiple fracture, so you no longer have the maxilla as a guide. Then the best you can do is do a model surgery with stone models. In pediatric mandible fractures, the goals are similar. You have to treat each area similarly. You can use the principles of osteosynthesis similarly, but you have three main problems. And your three main problems are, one, to limit the hardware to limit interference with growth. Two, when you do use hardware, and you'll probably use something more limited, such as wires or resorbable plates, that hardware needs to avoid unerupted future tooth buds, and your mandible is just filled with them. So what you do is you try to put the wires as inferiorly as possible. In addition, the teeth are conical for primary baby teeth, and so it's very difficult to establish real maxillomandibular fixation with wires. It can be very tricky, and that's where Dr. Mountain was talking about circumpiriform and other drop wires. So and so that's another way to gain maxillomandibular fixation, which is a must. Sometimes you can use wires. I have had scenarios where I've used OPDS or 2-OPDS in place of wires. If I only need a very brief period to avoid taking them back, you can just cut the wire. And then finally, their faster wound healing can both help and hurt. You can limit your time of maxillomandibular fixation, but if you have a precious condylar fracture, it may be very difficult to judge how many days you can really keep them in fixation. Finally, just briefly, geriatric mandible fractures, and this is brief because the principles are similar. The real key is a lot of these have edentulous or very limited teeth, and so you need either a denture or a gunning splint to simulate the height, or you just put the bone together as well as you can because they don't have normal occlusion anyways. And you have to be very careful. They're very brittle bone in geriatric mandible fractures. Good. So I think that's what our goal was to hit the 15-minute mark for do a few cases. Anyone have any questions at this point before we go on to cases? Wow, what a great crowd. Okay, well, I guess Dr. Mountain and I will just talk amongst ourselves with the cases in front of us. Okay.
I'm having a nice discussion with, I think, your resident, Roshan. So the pediatric aspect, I'll just, since the majority of my practice is kids, I'll just reiterate the fact that they heal faster, you got to get to them faster, stay away from the condyles, and stay away from those tooth buds. It is really hard in kids to do that. So all of your plates, if you do decide you're going to put in a plate, they're going to have to be at the very, very caudal edge, and they're going to be monocortical. And so that's the bad part about treating kids. The good part about treating kids is even in a kid that ends up with a malocclusion, with future growth, they tend to fight their way out of it, if you know what that means. So they're very malleable, I guess is a good way to put it, very forgiving in children, but also very difficult.
Yeah, I agree. We didn't have time to go through more about pediatric details, but they're malleable, they green stick, and they have lots of teeth. So you're basically operating on a shark.
I see that we have a question from guest number 4. Do you want to handle that one?
Sure. No, I'm a big fan of guest number 4. How do you decide when you're going to open a subcondylar fracture versus managing with closed reduction? When you do prefer a transparotid approach? Again, I tend, if there's a unilateral subcondylar fracture, I think most people in their practice would just do maxillomandibular fixation. If it's an adult, I will do maxillomandibular fixation for 2 to 3 weeks. In a child, I'll do 1 to 2 weeks, and then I'll do contralateral guiding elastics for about a month to help remodel that. Now, the slide before about indications for open, there is some data. It's retrospective. It's not perfect, suggesting that open reduction has better future jaw opening and jaw function. But I think most of us feel that the risk of opening and facial nerve injury, the risk-benefit ratio is unclear. And so we do try to limit this, in my practice at least, and Dr. Mount may chime in because it is a controversial subject. But for the, where's my slide on the condylar? Really, it's really about loss of vertical height. So in the bilateral scenario, I would do it. We sometimes see that in a panfacial, but it's open anyway, so the facial nerve is already way at risk. And but it could be an isolated bilateral. I think in an isolated bilateral subcondylar, I don't think MMF works, and maybe Dr. Mount will agree or disagree. In patients I've seen that happen to, that have been referred to me as a sequelae, they have an open bite because both posterior, they have premature contact at both sides, and then you have to do either mandible or maxillary surgery to re-rotate the maxilla down into the abnormal occlusal angle. And finally, we do talk about.
Can I make a
Please,
comment,
please.
Alex? I would totally agree with that, but if you do have a bilateral subcondylar displaced fracture, you don't actually have to open both sides.
Right,
All you
I
have
agree.
to
You
do
only
is
do one side.
Just to do even one side, because that's going to give you the post to keep your facial height where it needs to be. So don't risk the facial nerve and double your risk of a facial nerve injury. Just do one side.
Exactly. I agree. You just do one side. Unless you bag the facial nerve, then you do the other side.
So this is silly.
That's a joke. But it's very hard to read the audience in this scenario.
Everybody's laughing out loud online.
It doesn't matter. It doesn't bother me either way. It's I don't need that. It's just interesting.
All right. Let's handle the question from Lou. What do you use for post-op intraoral hygiene? Peridex.
Ah, Lou. Yes.
Peridex, Lou. But I tell you what, it has to be in a short span of time, because one potential complication with Peridex is the fact that it can cause some graying of the teeth, and the last thing you want is like this beautiful reduction, great occlusion, and gray teeth. So limit it to a week, maybe 10 days. But saltwater rinses are also a very cheap alternative and do the same thing.
Yes, salt water, and the other way to do it is I sometimes say half-strength mouthwash. Scope, Listerine, they have enough alcohol content, and it's probably just as reasonable. But there's no studies I know of.
Yeah. All right. Do you want to handle this next question, Alex?
Sure.
What is your opinion on hybrid MMF in the pediatric patient?
Oh, that would be an absolute no, because the hybrid plating systems, instead of basing arch bars on wires, it's basing arch bars on screws. And in the pediatric patient, we are trying to avoid screws because there's all these hidden tooth buds that are either partially developed or you can't even see them yet. And so that's a definite no.
I totally agree. I wouldn't use the hybrid on children because, again, those tooth buds are just all over the place, particularly in toddlers and like preschoolers. Sometimes the secondary teeth buds are actually at the level of the orbital rim, so there's not going to be a place, and mandible-wise all the way down to the border, so there's not going to be a good place for you to put that screw in where you're not going to disrupt some future teeth. All right, guess number 4.
Big fan of guess number 4. Yeah, big fan. They should do a movie about guess number 4.
Is there ever a role for resorbable plates for mandibular fixation? Yes, in children.
Yes.
I have not used them in adults. There have been a couple of studies that have indicated they have the same strength as titanium in adults. I'm just too chicken.
Yeah, I agree. I'm aware of 2 studies in adults, and for some reason they're both from Korea, which doesn't make any sense to me unless the factory that makes resorbable plates is in Korea or something. And they both show good results. They're retrospective studies. I think both of them were using Biomet, very thick Biomet resorbable plates. And I have not tried it either. It just doesn't seem strong enough for what the mandible needs to do, and it doesn't seem worth the risk. But for a child, like Dr. Mount was saying, I have used them in children. It's a great feeling to know they're going to go away without me having to go remove them, because I have seen kids getting titanium plates where you have to remove it later. It's interfering with growth. So that's nice. And guess number 4, did I see you in a TV show? Okay. All right, well, guess number 4 is, it keeps going. Let's see. Do you ever have patients? Do you ever refer patients for orthodontics after they've healed their fractures, especially if they have poor dentition at baseline? Oh, yes, definitely. So, boy.
Yeah, but if they have poor dentition, I don't know that the orthodontist is going to touch them, because to really get a good orthodontic result, you actually have to brush your teeth.
Right.
So, do we refer them to other specialists to handle their dental needs? Yeah, absolutely. Thanks for the question, Robbie. Or I mean, guess number 4.
Yeah, no, to have orthodontics work, you definitely need money, and then you need clean teeth. And I have asked orthodontists to help before for small alveolar fractures, for example, where all they need to do is put 2 brackets on 2 teeth and have them bonded across, and that's your tension band. Or someone who already has brackets, you can use that as your tension band. Pull a orthodontic wire there for a fracture that's relatively stable. Okay.
Let's do some cases.
Yeah, I think we have time for a couple cases. Let's start with this one. Oh, don't look. Okay. All right. Let's start with who is this?
How about guess number 4?
Yeah, guess number 4. Let's go with you first. No. What do you see here? What do you want to do? No, I'm just kidding. We don't have time for this. So this is a. Oh, okay. Good. Hopefully reveal the masked person soon. Yeah, I agree. This is a left mandibular angle fracture, and.
Tell us what.
This is not trolling, right? Is this trolling? This is not trolling, right? This is like reverse trolling, right? It's like positive.
This is positive
trolling.
Actually, we have a competition between Brian and guest number 4. Good.
So.
Oh, excellent.
That seems very reasonable. And you can see, I like the lower picture there to show you what this patient's complaining of, and they're complaining of left open bite, and this is a teenager, 18-year-old. What do you, yeah, Champy, no, right, no, I knew you didn't mean champ. Yeah, Champy plate, agreed. So here's a picture of so I used maxillomandibular fixation screws that you can see here and here, and there's a Champy plate right there. Now I know what Lou's going to ask. Lou's going to ask what I did with the teeth. Oh, I can't tell. All right, we'll go to the next case, I guess. That was a great case.
I want teeth like this. I mean, this is good.
We'll check the opposite side. Place tension band above and a small profile recon plate below. I'm not sure what you mean, Lou, but your writing is good, but I don't know what you mean. Place tension band above. I know what they mean. They're saying, alternatively to a Champy plate, could we put a band above and a band below? And Roshan said that too. That's what they mean. Yeah, I think you could do that. But a Champy plate is so easy, and this fracture is so reasonably aligned that I think that's fine. I'm not sure what the check on the opposite side means, but. Okay, so here's one of the most common combinations you'll see, and I feel like we see these weekly in the summers. And this is a 19-year-old with a right. Oh well, what do we see here? Yes, Lou, I agree with Lou. No contralateral fracture. I agree. I agree.
Absolutely.
Absolutely.
Yeah, also check for number 2. Yeah,
I agree.
good job.
Very good job. So, what do you guys want to do here for a, what do you see, what do you want to do? Yep, right angle, left parasymphysis. I agree. And this is really super common combination. The mandible acts sort of like a ring, so when you drop it, it breaks in 2 places. I never knew what that meant, that a ring has to break in 2 places, but that's what we say. And I don't know, and this is very common. Usually it's the contralateral, not the ipsilateral parasymphysis, although I've seen that before, but it's usually like this. Right compy, left border plus a tension band. Okay, sure. A right chompy, left border plus a tension band. What do you want to use for your tension band?
Hey, Alex, since you have control of the green marker, can you show where you would place those plates?
Okay, sure. So, actually, we can even give a guest. I just saw that here. A guest can even draw, potentially. So, right along the external oblique ridge. Ooh, someone said box plate.
Box plate would work.
Yeah, let's box plate that. Cool. Good. Let him swing with a champy? Z, would you let them, say that you put a box plate and a champy, would you let them swing or you'd MMF them? Yep, depends on the reliability of the patient. Let's say it's a reliable patient. You'd let him swing? Yeah, I think you can let a champy plate swing, even though if you take a Panorex after a champy plate, you'll see that the inferior border is a little bit separated, but you're relying on that load sharing along good bone-bone contact. So yes, I agree, but if they're unreliable or a child, I'd probably MMF them a little bit.
Yeah, I want to give a shout out to Brian who said MMF, because I that's probably what I do most frequently is MMF and then a lower border plate. I don't think the MMF by itself is going to do it, but that's a good idea for the MMF.
MMF with a parasymphysial plate or an angle plate?
With an angle plate and a lower border plate. But I like the, I mean, you could do a champy too, but if you're going to, yeah, I mean, all of those are options.
Sorry, say that again. You would do a parasymphysis plate and MMF?
Yeah, and then for the angle, either a champy or a lower border plate with a tension band through a not an open or transcutaneous, but through a transbuccal trocar.
Got it. But how is that different than this? I thought you meant you would do MMF with nothing else. That would be interesting.
I don't think that's what Brian meant either, right, Brian? Yes. Yeah.
Right.
But you don't have to put a dental wire on if you've got your MMF on, because that's going to control your proximal.
Yeah, I agree. You don't have to put the wire in if you do an MMF. I agree. Brian says he's never had a reliable facial fracture patient. Oh, Brian.
So, Roshan, when you said transoral, do you mean with a buccal trocar, or I hate making resident incisions. I think they're ugly, so I try to do as much as I can through an intraoral incision with just a small transbuccal stab. Percutaneous screw. See, explain that one. Oh, it's right there, yeah. Okay.
Okay. Well, I think we're running out of time. It's too bad. This was the next one was pretty good.
Let's just do one more. Let's just for fun. If anybody has to leave, they can.
Okay.
But
All right.
audience participation is great. So let's go with it.
It's
All
wonderful.
right, well, this is an adult. This is a 38-year-old.
Roshan, did you do this case? You can't comment.
Well, look at that, Dr. Mount. Multiple attendees are typing.
Awesome.
This is the most interaction we've ever had in these webinars.
A St.
This is
Louis special. Is that what we're going to call these now? St. Louis special?
oh, totally the butterfly segment. There's like two butterflies. This is like a butterfly forest.
Guess number 4. What would you do? What about guess number 1, 2, and 3?
I think they all
We haven't
belong
heard
to
it.
guest number 4. He opened the 3 accounts.
The lingual cortex is going to be very tough on this case.
Do we do most valued participant at the end of this?
We could definitely do that. It would take some post-meeting evaluation, I think.
Everybody come to the basic course. Next month it's in Philadelphia. Next August it's in Chicago. You can take a big caravan up from St. Louis. It'll be great.
I think it's in Philadelphia this year, though.
No, it's in Philadelphia next month.
Right, okay.
Chicago in August of 28.
Right, next
That's
year.
right.
Yep.
The very end of July in Philadelphia.
Well, I agree with guest. I mean, there's a lot of ways to do this. I think recon plate along the right parasum, separate along the left mandibular border. Right, I think that's very reasonable. I mean, this is a mess. I would also probably remove this tooth down here. I think is probably going to go. I'd probably remove this tooth as well. How about you, Dr. Mount? I don't know if you would, but
I'm conservative. If they get in the way of the reduction, yes, I'm going to take them out. If they help with a reduction, I'm going to keep them even if they're fractured, and then let the dentist take them out later on after the fracture's healed. But if they interfere with the reduction, which I think both of them will, I would take them out like you're saying.
I think that's reasonable.
Now, one other point that I'd like to make that Alex made earlier is there are some fractures that you're going to expose all the fracture line before you put them into MMF. And I think this is definitely going to be a patient that you're going to do that. Imagine trying to put either hybrid arch bars or standard MMF on this patient. You're gonna displace them with your arch bar. So this is going to be one that you may put on the maxillary arch bar. Go ahead and expose all of your fractures. Try to
Good. Well, I think those are all reasonable things. I saw recon plates, reasonable. You could also do mini plates with good arch bar MMF. That's possible. Doing smaller mini plates rather than a big recon mini plate, small to hold the butterfly. You could consider throwing away tiny segments that are probably just going to get infected, especially if they're in line of the teeth. This is a tough case because there's a lot that could go wrong. All right, well, it's 8:09, so I need to have my last coffee of the day.
Are there any more questions for the presenters? Well, I must say that this has been the most interactive webinar we've had, the most informative. I think the audience participation has been wonderful. I'd like to thank Drs. Mount and Lin for their presentations this evening, and certainly their banter with each other, which I think has been most entertaining. As was pointed out during the webinar, the next basic course of the ASMS is the summer basic, and that's going to be taking place at the tail end of this month. Tail end of July in Philadelphia. At the close of the webinar, you will see the ASMS website will appear, and feel free to navigate to the educational programs page, and you will see information about that basic course. Doctors Mount and Lynn, do you have anything else to share with us?
No. Yeah, no, thanks, Stan, for organizing this, and thanks to all the participants. If you were not here, it would just be Dr. Mount and I sitting at a bar talking about mandible fractures, and that's pretty old news.
Yes, with guest number 4.
Guess number 4. Guess number 4.
All right. Well, if there's nothing more to present this evening or chatter about, then we will conclude the webinar. And thank you all so much for attending. And again, thank you, Drs. Mount and Lynn. This was wonderful. Yes, the web address is www.maxface.org. And again, it will automatically appear at the close of the webinar. Very good, Alex. Thank you.
Good night.
Good night, all. Thank you.